Thank you everyone for joining the Ear Research Foundation's Hearing Education Series. Today's topic is Dizziness and Meniere's disease with Dr. Herbert Silverstein, founder and president of the Ear Research Foundation, and Gabrielle Rosenwald, audiologist at First Physicians Group. And now I'm going to pass over to Dr. Silverstein so he can start the presentation.
Thank you, Christina. Well, today we're going to talk about you don't have to be dizzy. And we're going to talk about different diseases that cause dizziness and imbalance and what the treatment is available today. How do I get this over? So I'm going to first talk about the anatomy of the ear and the balance center. This is a picture of the eardrum. Actually, it's a very beautiful picture. The eardrum is like a window. You can look through it many times if it's normal and see the little bones of hearing. This is the malleus bone here, and you can see the incus and the stapes bone here underneath. We'll see that more later. So we have the outer ear, which has the pinna of the ear that brings the sound into the ear canal, the external canal here, and the eardrum here. So the middle ear, you have the tympanic membrane and the three ossicles, malleus, incus, and stapes. And then we have two windows, the oval and the round window, and these windows vibrate in response to sound. When the sound comes in and moves the eardrum, the little bones of hearing act like a transformer and increase the vibrations. And then the sound, the stapes bone then vibrates the fluids of the inner ear, which then activate the fluids around the cochlea and produce sound, which goes down the eighth nerve. So again, here you can see the ear canal, the eardrum, and the three bones of hearing. Now, the inner ear is made up of the cochlea, which is the hearing organ, and the labyrinth or the balance and equilibrium mechanism, and the eighth nerve. So these are the semicircular canals here, the superior semicircular canal, the horizontal and the posterior canal, and the labyrinth here. And the cochlea is like a snail in a circle here with the eighth nerve. So how do we balance? Well, balance is really an unconscious act, and you can think of yourself as a tripod. And the input to the tripod is your ears, balance canals, your eyes, and the proprioception are your muscles and joints. And the brain organizes this information. The input goes into the brain, and the brain organizes the impulses coming in from the ears, eyes, and proprioception. And then the output goes to the muscles and joints and keeps you in balance. Here's another picture of the inner ear with the cochlea here and the semicircular canals and the labyrinth here. So the common causes of dizziness, the most common cause that we see in the office is benign positional vertigo. And we'll talk about that shortly. The second most common is Meniere's disease. And third is labyrinthitis or vestibular neuritis, and we'll explain that. And neurological diseases, and then circulatory cerebral diseases. So benign positional vertigo, we'll talk about that first. Symptoms occur usually only rolling over or looking up, and the symptoms only last for a few seconds, from 15 to 30 seconds. There are no symptoms unless there is movement. The treatment is the Epley maneuver. The Epley maneuver, we'll show you this shortly, was developed by Dr. Epley in Seattle, Washington, many years ago. And the way we do the Epley maneuver is that we take the ear that's affected and we take the patient and put the patient from the sitting position to the lying position with the head turned to the side of the dizziness. So if you get dizzy rolling over on the left side, it's usually your left inner ear that's causing the problem. And most of the people today talk about crystals floating around in the inner ear. And that's the way to think about it, is that when you turn your head, the crystals stimulate the balance canal and you get dizziness as the little crystals float past the ampulla of the semicircular canal. So it takes about 3 minutes. We put your head in the left position, say if you have a left problem, for 1 minute. And then the second position is you have the patient sit up and then go down on the other side. And then the third position is with the head straight back. And these are shown here on this picture. In the internet, there are different websites that will show you how to do the Epley maneuver correctly. And you can do it on yourself at home on the bed by just lying back with your head tilted to one side for 1 minute and then sitting up and then tilting your head to the other side and lying down. Then we have the patients roll over and look down for another minute. The results are excellent, and sometimes it takes 2 or 3 of these Epley maneuvers to get the crystals organized and stop causing the dizzy spells. But it's interesting that even after you do this, the patient can have unsteadiness or feeling of imbalance for a month or so after the positional vertigo and not be perfectly cured. So this shows the position again, one side for 1 minute and then the other side, and then with the head back. And then we have the patient roll over also. Now, if the patient doesn't get better after 12 months and you've done the Epley maneuver many times, then occlusion of the superior semicircular canal stops the vertigo, and the results are excellent. We've done many of these operations, and before the Epley maneuver, we would do the surgery for the patients rather than do the Epley maneuver. The results are excellent, and they're usually lasting. They last a long time. Now, in Meniere's disease, it's an inner ear problem, and it's related to recurrent episodes of vertigo, and you need to have recurrent episodes of vertigo for Meniere's disease. Why is this going? Also, patients have fluctuating hearing loss in the ear, usually low tone hearing loss. That usually gets worse with the episodes of vertigo. They also can have roaring tinnitus in the ear and pressure and fullness in the ear during the attack of vertigo. The attacks of vertigo usually last from minutes to hours. They can see the room spinning around. They're unable to walk. A lot of times there's nausea and vomiting, and most patients have to go to bed when they're having an attack of Meniere's disease. So the hearing loss many times can occur before the vertigo starts, and it's a low frequency hearing loss at first. The hearing fluctuates, goes up and down, usually gets worse with the attacks of vertigo. And there's also associated fullness and pressure in the ear. And it seems to get progressively worse over time. Now, we believe that Meniere's disease can be aborted by early treatment, and we'll talk about that shortly. One of the ways we make a diagnosis of Meniere's disease is with a tuning fork. And we place the tuning fork, is 250 hertz tuning fork in both ears. And the patient usually hears the sound at a different pitch if they have Meniere's disease. That's called diplacousis, and no other condition causes diplacousis other than Meniere's disease due to the extra pressure in the inner ear. So with a tuning fork, you can make a diagnosis almost every time. So how do we treat the attacks? Well, Ativan is the latest and greatest treatment. It's 0.5 milligram of Ativan, and you put that underneath your tongue, and it's absorbed very quickly, and it usually will abort the Meniere's attack. It may make the attack less severe. Meclizine, which is antivert, is the common drug that's been used for years. The problem is that it takes about 45 minutes for the meclizine to be absorbed by the stomach and start to work, and where the Ativan works right away. Compazine and phenergan suppositories can be used for the nausea and vomiting. Bed rest and reassurance. Many times patients with their first attack of Meniere's disease go to the emergency room because they think they have a stroke or something very serious happening. So there are various types of Meniere's disease. There's this subclinical type. This is the one where the tuning fork is heard differently in either ear, and there may be a small low frequency hearing loss in the affected ear. Then there's cochlear Meniere's disease, where you see a low frequency hearing loss that fluctuates. Patients usually have pressure and fullness in the ear and tinnitus, ringing in the ear. And then vestibular Meniere's disease is a condition where the patient has the spinning spells of vertigo, but they do not have a hearing loss, and they get recurrent spells of vertigo from time to time. And then there's the classical Meniere's disease that has the hearing loss symptoms and the vertigo symptoms at the same time. There's also a condition called bilateral Meniere's disease, which is, we call it autoimmune inner ear disease. And there's also a condition called delayed endolymphatic hydrops, which is when one ear is damaged. Many years later, the other ear can develop Meniere's disease due to an allergic reaction. So the treatment between the attacks is we usually place the patients on diuretics, triamterene, diazide, or Diamox. Diamox is the best drug to take, but sometimes the patients don't like taking it because they get numbness of their tongue and fingers, but it's probably the best diuretic for Meniere's disease. And we reduce the salt intake, treating the patients with prednisone, high dose of prednisone for several weeks. Will sometimes abort the attacks. Beta histine is a very good drug. You can take 8 milligrams TI 3 times a day, or take 16 milligrams 3 times a day. And then there's a procedure that I developed called a microwick and an inner ear perfusion with dexamethasone. So what we do is we take the patient and we numb the ear with some drops that I developed that numb the eardrum. And then with the laser, we make a little opening in the eardrum. And then we put a little wick in. And that wick goes through the eardrum and then it goes into the round window, which is a thin membrane. It's like the cornea of your eye. And this allows the medications to be absorbed into the inner ear. So if you put dexamethasone or any medications here, this starts to swell and the medication goes down the wick to the round window and it gets absorbed into the inner ear. And that gets into in the highest concentrations. If you give prednisone by mouth, some gets into the inner ear, but not as much as when you treat it directly with the microwick. So we usually leave the wick in for 1 month and then take the wick out. And then the eardrum usually heals by itself over a period of a couple of weeks. This is a picture of what the wick looks in place after it's been saturated with medication. There's a little tube that we placed in the eardrum that holds the wick in place. So they can instill 3 drops of the dexamethasone 3 times a day for 1 month. So when vertigo is the main complaint, we treat the patients with, we can treat the patients with a microwick and perfuse their inner ear with gentamicin. For several weeks, we dilute the gentamicin and the patient instills the drops into the inner ear several times a day. And we see the patients weekly to make sure to see when to stop the treatment. In this treatment, the gentamicin acts to destroy the balance mechanism of the inner ear. Today, we're treating mostly patients with steroids. We use the gentamicin for the patients that are having severe attacks and can't be controlled with the steroids. The microwick is a simple, easy, inexpensive office procedure. And it's an excellent way of delivering medications to the inner ear. So vestibular neuritis is a viral infection of the inner ear. And what happens is the vertigo lasts for 4 to 8 hours, sometimes even longer. And the patients are usually taken to the hospital and they stay in the hospital for a day or so and get medications to try to feel better. And afterwards, they need vestibular rehabilitation exercises to get their balance back. What happens is the virus goes in to the inner ear and it destroys the balance nerve. And so it takes months to develop your balance again by doing various exercises, rehabilitation exercises. And usually you have to do those exercises twice a day for the rest of your life to keep your balance as good as it can be. So chronic imbalance, usually caused by decreased cerebral circulation of aging. As we get older, we have a tendency to lose our balance. And many times excessive medication can cause imbalance. Like I said, aging, hereditary causes, and a loss of vestibular function as we age. So the treatment of chronic imbalance is the vestibular rehabilitation exercises from a physical therapist, and that usually lasts for several weeks. Patient does these exercises at home twice a day forever, and the results are quite excellent. And the last thing, this is not related to dizziness, but this is something that I invented about 10 years ago called ear care. It's alcohol and aloe combination. And we have it on a special tip here where you squirt the alcohol and aloe in your ear twice a week. say in the shower or over the sink to decrease the wax accumulation in your inner ear. And it also keeps the Q-tips out of the ear, which you shouldn't be using. So now Gabrielle Rosenwald will talk to you a little bit about balance and how we test patients with this problem.
Hello, thank you everybody for joining us today. I'm Dr. Gabrielle Rosenwald, and thank you for talking about all of the different pathologies that might happen in the ear. Whenever we're trying to figure out what could be going on with the ears, we always need to do a series of different tests so that we can figure out if your dizziness might be caused by the ear, the brain, or something else going on. So we do a full test battery to understand the dizziness system and the balance system, which, like Dr. Silverstein had mentioned, is comprised of the vestibular system, or your balance in your ears, your visual system, just what are you seeing in your environment, and your proprioception. So what are the different sensory inputs that your feet are getting, your hands touching different objects, sending it up to the brain, and then your brain is able to combine all of those different sensory systems to keep you upright. So whenever we're trying to figure out where dizziness could be coming from, we have to do a lot of different types of tests, sort of like putting lots of tiny puzzle pieces together so we can figure out different patterns of where dizziness could come from. So we'll go through all of these different tests, so don't feel like you have to memorize them right away, but we'll start off by doing a hearing evaluation. So if you are one of those patients who might be confused as to why we're doing a hearing test, some patients will tell me, I'm here for dizziness. Why do you want to test my hearing? And at the end of the day, we want to test that hearing organ because the place that the cochlea lies is actually housed in the same cavity as the vestibular system. So because they have a connection, they could share a reciprocal relationship with one another, where the cochlea or hearing side could affect the balance side as well, or the balance side could affect the hearing side, and then the nerves that are attached to those organs could play a role on one another. So whenever we start with a hearing test, we'll look at a few things in particular to help us understand what could the potential diagnosis be. So first, we'll look at the degree of your hearing loss. We want to know, one, do you have a hearing loss and how severe is it? We want to see what the configuration looks like. So does the type of hearing loss that you have indicate any sort of pathology like Meniere's disease or something like a canal dehiscence, where there's a hole in one of the canals? We also want to see what the type is. So is your hearing loss in your inner ear only, or is it somewhere else in the system? And then we'll also want to see if there's any kind of asymmetry between the ears that could indicate that one ear has been affected, but not the other. When we do a hearing test, we have to include some middle ear testing, so we get some good structural information. When we do this, we evaluate whether or not the eardrum is responding correctly when we add negative and positive pressure. We'll also check for perforations, and we'll also try to see if there's any kind of fluid that maybe we can't see behind the eardrum when we just look in. And then we'll also see if the middle ear bones in our middle ear system are either moving too much, moving too little, or if they're moving just right. We'll do this with tympanometry and checking a reflex in your ear. And then we'll also do otoacoustic emissions, or OAEs. This is a really powerful test that we can use to see at the cellular level, our outer hair cells or tiny little hair cells in our hearing organ, are those sending signals up to the brain like they should when we hear a sound? This can be really important because sometimes you might have some structural damage to this part of the organ, but not necessarily to your actual hearing test. So this can be really good for monitoring your hearing over time, especially when you're exposed to intense treatments like chemotherapy, or if you're exposed to noise over the course of your lifetime. So once we get all of the hearing evaluation complete, we focus again wholeheartedly on the balance system. We want to understand that three-legged stool and where dizziness could be coming from. So we have to test each part in a different way and then put that puzzle piece together as well. So we can start off by looking at your balance with some really cool equipment called computerized dynamic posturography. This is a balance test that helps us understand how you're using your balance in various different situations. And this is the part of the test battery where you get to become an astronaut, since this technology was actually developed by NASA to help figure out what the astronauts use their balance like once they return to space. So when you are hooked up to this equipment, you stand on a plate that can move, and then you get to be an astronaut and do a series of different tests for 30 minutes. One of those tests could be a sensory organization test, where we can put you in certain situations where either the plate under your feet will move so that we can see how you're using your balance, and then we can determine if the imbalance that you have is from either a somatosensory point of view, a visual, or a vestibular. We want to see if there's any preference for one versus the other, or if one is not getting utilized as much as it needs to. We can also do an adaptation test where we can actually change how the floor is moving underneath you to see how able are you to keep yourself upright when there is an abrupt change in what you're standing on. We can also do a motor control test, which is essentially moving the plate up and moving the plate down under your feet to see where you're using the control and your musculature in your body to keep yourself upright. So when we do all three of these tests, we can get a really good understanding of how are you using your balance, what situations in particular can be difficult, and we can also see if there's any kind of central component based on what the pattern looks like. And then we can also make sure that you get the best type of recommendation for physical therapy, like Dr. Silverstein had mentioned. So once we get some balance testing done, we can move on into video nystagmography, or we can just call it a VNG. This is the point in the test where we put some goggles over your eyes, and we're going to look at how your eyes move whenever we give you something to look at or when we take your vision away. This helps us figure out how the inner ear is working and how it's talking to the brain at all times. The goggles are pretty cool. They are just infrared lights, and they can track even the tiniest of eye movements. When we do the VNG testing, it's broken up into 3 separate sections. We'll start off with ocular motor testing, where we can actually have you looking at an object, positional testing, where you'll have your eyes covered, and calorics, where you'll have your eyes covered. And then we also put in air in your ears. Talking more specifically about the ocular motor testing that we do, this is a series of tests where, again, we put a stimulus in front of you and tell you to either track it or to respond to it. And we try to see, are your eyes moving correctly? When we do saccade testing, we basically put a dot in front of you on a big TV screen, and it jumps around the screen. And we just want you to follow it wherever it goes. In smooth pursuit testing, the dot will move very slowly and then sort of change speeds and go pretty quickly. And we want to see if you can follow the dot right on it instead of going too far ahead or behind. Then in gaze testing, we'll just give you a dot to look at, and you just need to follow it where it goes and it'll stay stable. And then in optokinetic testing, or OPK testing, we'll give you a very complex pattern to look at. So think of bars on a screen or a lot of bubbles. And we're just testing a reflex that your eyes have when you see a pattern moving. And sort of like if you're on a bus or a train or a car and you see trees moving past you in the window. So these tests are really helpful for us to understand, are you able to track a stimulus, and are the ears and the brain talking to one another correctly? Then we'll move on into positional testing. And this is where we want to see if your eyes are moving appropriately when we lay you down, or if we can provoke any sort of dizziness or eye movement. Since eye movement is one of the big tells of either a ear-related dizziness or a central-related dizziness. So we'll do a Dix-Hall pike. So we'll put you in a position where your neck is, or your head is hyperextended. So we can see if you have potentially any BPPV, or what Dr. Silverstein mentioned earlier, like with the crystals. So we want to check if you have any crystals out of place. Then we'll lay you down completely flat and we'll take the eyesight away. We'll just put the cover over the goggles so you won't see anything. And we'll see what your eyes do. Are they staying still? Are they moving? Which direction? We know all of that. And then we turn your head in both directions. And depending on what we see, we'll have you lay on the side just to see if you're laying in bed, what your eyes would do at that point. And again, this just helps us figure out what are your eyes doing when they have nothing to look at. And then that helps us figure out certain patterns to give us an indication of where your dizziness could come from. And then in VNG testing, there are calorics, which are a very powerful tool to help us figure out which ear might be weaker than the other. So we'll put in warm and cool air into your ears one at a time, and we stimulate the system one at a time. So what we're doing is putting in that air in your ears, which depending on the temperature changes the fluid composition in your ear, which should make you feel like you're moving in one direction or the other. When that happens, we want your brain to tell your eyes to move accordingly so that we can see if your eyes are able to respond based on whatever your ear is telling you. So this is a really great test for us to see, one, is there a weakness in one system or the other? And then we also want to see, are the ears, eyes, and brain all talking to each other at the same time? And then we get into some rotational chair testing. So this is helping us really understand what the vestibular ocular reflex is doing, which is essentially our ability to remain stable on an object whenever we move our bodies around. So this is a reflex that is important if we are, let's say, walking across the street and we see a sign that we want to read. We can still move our legs, but make sure that our eyes are able to read the sign and keep fixation on that sign itself. It's important when we are moving around and we want to talk to someone next to us and make sure we're remaining stable on them. So when we do that type of testing, what we'll do is keep the cover over the goggles so you won't see anything. And then we'll rotate the chair very slowly and we'll change the speeds so that we can see how your eyes are moving at those different speeds. This helps us figure out if there's any kind of loss or weakness in one or the other of your ears, and we'll change up how the chair moves. So sometimes the chair will just do a full rotation. Sometimes it'll go in a back and forth manner, sort of like a teeter-totter. Well, not a teeter-totter, but just back and forth. And whenever we do that, we can also compare these results to caloric testing again to make sure that we can see how the brain has adjusted to the healing process to see if you've recovered from any potential weakness that your system might have. Moving on into more neural testing, we have what's called an auditory brainstem response, or ABR testing. This is a great tool for us to use so that we can measure how the auditory nerve is responding when you hear a sound. So this is sort of like an EKG of the ears. This is different from the hearing test. Since we already have done the hearing test, we know what you hear. This test is helping us figure out what is your auditory nerve doing with the sound. So we'll be able to see what you are doing with the sound, and we'll just do that by scrubbing a couple spots on your forehead, in your ears, and then we measure the response of your brain activity. Then right after we do that sort of testing, we'll move on into an electrocochleography or an ECOG. This is a really great tool to help us figure out what the electrical response from the actual inner ear is doing and how it's communicating with the auditory nerve. This is a great tool for us to figure out if there's any potential for endolymphatic hydrops or Meniere's disease. Then we might do some vestibular evoked myogenic potentials, or VEMP testing. This is a really powerful tool to see what not only the ears are doing, but what the brain might be doing as well. This will test the saccule of the inner ear system as well as the inferior vestibular nerve. And then it will also test some central brain connections. So because it can test both inner ear structures and central inputs and outputs, it's very helpful for us to investigate whether something is ear-related in terms of migraines, Meniere's, semicircular canal dehiscence, or if we have something else going on. We test this VEMP by essentially similarly to a auditory brainstem response. We'll scrub a couple spots on your forehead, but this time we'll also scrub a spot on your neck so that we can make sure to put some stickers here. And then we want to record the sternocleidomastoid or SCM muscle. That's that big bulging muscle that comes up if you turn your head. So we'll ask you to lift your head up and turn to a specific direction so we get some really good musculature popping. And then we'll essentially have you listen to some like woodpecker sounds so that we can figure out how is that sound being transduced through your ears. So that is a lot of testing that we have to do. But again, we want to make sure that we're getting a really good puzzle piece put together one by one so we can really figure out where the dizziness is coming from. When we figure out where the dizziness can come from, we can make sure that you get the best sort of treatment protocols and best outcomes for you specifically. So maybe if Mr. Humpty Dumpty here would have seen us at this clinic, he could have prevented some falls and hidden his hard shell. So come see us if you experience any dizziness at all, and we'll definitely figure out where that dizziness is coming from and how we can help you out. But yeah, thank you so much for coming and joining us today for this webinar and learning about dizziness with us.
Yeah, can we get some questions
If
now?
there's any questions, they can send them to the chat and.
Yeah, if you weren't able to hear that, you're welcome to put some questions into the chat if you have any.
Can we ask the questions or?
Yeah.
Yeah, go for it.
Okay. Hey, first of all, great presentation. Good stuff. Just so you have my state, I've been diagnosed with classic Meniere's along with vestibular migraines. And Dr. Silverstein, I've got a couple of questions directly for you. Are there other professionals doing this micro-WIC that you've done?
Well, my fellows that I've trained are using it.
Okay.
And
well, I'm in Texas, and that's why I was asking the question. And I certainly see this as a nice opportunity. So
we have three, I think 2 or 3 doctors in Texas that we've trained.
Okay.
And we could send you the where they are and everything.
Okay, yeah, that would be great. And the ear care, can we order this from you by any chance?
It's on Amazon or earcare.com.
Okay.
Either one, Amazon will send it
Perfect.
to you.
And I know there's been a lot of back and forth regarding salt and the issue with migraines and Meniere's, and I've been on a salt-free diet pretty much for the last 3 years. And I'm not convinced that that's really helping. Has there been any further studies on the relationship with salt or?
Migraines. Some people believe that Meniere's is a form of migraine, and there's some people in the country now that are treating Meniere's disease like migraine patients, and so the drug Diamox helps both of those conditions. So Diamox is a diuretic, but it does help migraine. People with migraine headaches. I think if you have migraines, I think they certainly can cause vertigo attacks, and there is a connection between the migraines and Meniere's disease. But a lot of patients don't have the migraine symptoms, and if they don't have the symptoms, I don't think that it's worth treating them like migraine patients. If they have headaches, then I think that then it's worth the treatment. But some doctors are treating Meniere's patients as if they were migraine patients completely, and not worrying about whether they have the attacks or the headaches. If they have the headaches, they're going to, if they have vertigo attacks, whether they have the headaches or not, they'll treat them as migraine patients. And
Okay.
I'm not sure whether that's the way to go. One of the problems with Meniere's disease is that it goes away by itself. So it's hard to know what if we're doing different things to the patient. If we do a labyrinthectomy, which I didn't talk about, or a vestibular neurectomy, which is an operation that I developed, where we cut the balance nerve to the inner ear, that will cure the attacks of vertigo, but it won't cure the Meniere's disease. Patients will still have the fluctuating hearing loss, but it will stop the vertigo attacks. Also, when we first started treating Meniere's disease many years ago, we would do labyrinthectomies on the patients. In other words, we would destroy the inner ear, and that would actually cure the patient. We would never see the patient after that. After they got over their imbalance, they would never have another attack of vertigo unless they got it in the other ear, which was at about 10%. So I don't know, what was your question?
Yeah, no, I think you certainly answered that. You did mention the duration of Meniere's, and I've heard that it can certainly go away after a period of time.
Right.
Is there a classic time frame that people could count on? Hey, this is going to be gone in 3 years, 5 years, 10 years?
No, there isn't. It's a really fickle disease, and it's really hard to predict what it's going to do. So it's one of those things that usually when the hearing gets down to about 70% loss, a flat type of hearing loss, patients usually stop having the vertigo attacks. And we call it the Meniere's burns out, and they just are left with the hearing loss, and they don't have the vertigo attacks anymore.
Okay, perfect.
But the how long it takes is really individual.
Perfect. Okay, thank you. And then one last question. I've been given information that's.
Let me make one other point, that my concept is that if you can catch the patient early, when they've had their first attack, and you blast them with steroids by mouth and put a wick in their ear and put it in the inner ear. A lot of doctors are injecting these steroids in the ear because it's a lot easier procedure than using the microwick. So many of them are injecting the steroids into the ear, but I don't like that technique because the steroids go right down the eustachian tube, and very little of it goes into the inner ear. And but I think that's
There's some questions in the chat.
there's some more questions. Okay.
Thank you.
Read them to everyone.
I can read them so that they can hear. So Mid Shepherd asked, I have my Meniere's disease and had a few drop attacks. Can anything be done to avert this?
Yeah. Drop attacks are very serious with Meniere's disease. The reason they're serious is that you can break bones, and many patients will fall and they'll be wide awake and they'll hit the ground, and they'll not have a vertigo attack, but it'll just be a fall. And we used to consider those emergencies and operate on those patients right away. But I think that if you have drop attacks, I think you should definitely have treatment with gentamicin to try to control that, because you're going to hurt yourself.
Yes, but then you lose your balance, and I've already had a labyrinthectomy in my other ear. So I don't think I can't get that in the remaining ear, correct? Because then I'd have no balance.
You mean the gentamicin in your only hearing ear?
Yeah, the one ear has got a labyrinthectomy. So
Right.
can you do the gentamicin in the only other ear?
No, I don't think you can.
So there's nothing to do to try to avoid the drop attack.
So you're having drop attacks when you and you've had a Meniere's. Do you think the Meniere's is in the other ear now?
Oh, it definitely is. I have vertigo in the other ear also.
Well, I think you need to have it treated, definitely. We have done when we've used gentamicin, it's destroyed the balance center on both ears if you inject it. You can inject streptomycin, which is like gentamicin, and that will destroy the balance center in both ears in patients with bilateral Meniere's disease. And those patients, even with no balance system in either ear, can still function. They have a wide base gait, and they have difficulty driving at night because they have what we call oscillopsia. The light goes up and down when they're looking out at different lights. They jump up and down if you've had loss of balance in both ears. But you know, I think that steroids, have you had steroids injected into the only hearing ear? Have you had steroids injected into your only hearing ear?
I've had a couple of years ago into the other ear, but that was before drop attacks.
Yeah, I think you should have some steroids put in your right ear. And a dilute solution of gentamicin may be indicated even in your only hearing ear. Depends upon, you know, how many you're having and what's going on.
Yeah.
But I definitely
I've had
would.
this for 50 years. I'm pretty tired of it.
Where are you living now? Where are you living?
Connecticut, outside New York City. So do you have somebody in New York City?
We do. Eric Smuha. Look him up, Eric Smuha.
SMUHA?
I'll put it in the chat.
We're going to put that name in the chat.
We're going to put it in the chat for you to see.
Okay.
He can help you.
Yeah. Another question. We'll move to Mark Weinberg. How can you determine if hearing loss is due to Meniere's or due to aging or hereditary causes?
The aging hearing loss is usually high frequency, and Meniere's disease is classically low frequency. And sometimes when I see a patient with a low frequency hearing loss and it goes up, peaks, and then it goes down in the higher frequencies, I tell them that you can see the name Meniere's disease written along the hearing loss because it's so classic. So if you have a low frequency hearing loss that's fluctuating, or that it's in the low frequencies, it's probably caused by too much pressure in the inner ear and Meniere's disease.
Thank you, Doctor.
Let's move to Todd here. Todd Kostrenzwa. Sorry if I did not say that right. Are there any lifestyle changes that improve the Meniere's condition without using drugs or performing surgery, foods to avoid, things like that?
What was the question again?
Are there lifestyle changes to improve Meniere's?
Lifestyle. Well, no drinking and no coffee. That's helpful. Obviously, a lot of sleep and decreasing anxiety all help.
Low salt diet.
Low salt diet, yeah.
And then based on your comments, is there any correlation with this and ocular migraines?
No.
Henrik Michael asks, hi, I'm diagnosed with Meniere's disease and recently went through surgery to decompress the eustachian sac. After more than 1 month of surgery, I still have significant fullness in the ear, which is worse than pre-surgery. It seems that there is significant inflammation. What can be done to improve this?
I think a microwick would help. It's putting steroids in your ear and going on steroids. I wrote a paper on that endolymphatic sac procedure, which I don't believe works. And in 1995, I got up at a national meeting and I said, this operation won't be being done because it doesn't work. And I was totally wrong because it's still being done by some people in the country, but I don't think that it really does much. And in your case, it may have made the situation worse. But I think treating with steroids would help you at this stage, and low salt and a diuretic.
Mike Weinberg asks, is it possible to have 1 or 2 severe Meniere's attacks and then they cease completely? If this happens, could the Meniere's diagnosis be an error?
Yeah, it could be an error. Usually if you've had 2 attacks, I would say it probably is Meniere's if you've had the fullness and the pressure and the tinnitus and the other symptoms that go along with it. If you just had 2 separate vertigo attacks, it could be due to a viral infection. And it may not be Meniere's disease. And sometimes it can go away, just like you said, it's a very fickle disease. And after studying it for 60 years and doing a lot of research and animal work, we still don't have all the answers yet. But the only thing that I know is that if you catch it early, you can abort it if you treat it with high doses of steroids early.
All right, thank you.
And then Jerry Carsonson says, what about drop attacks and can upper cervical treatment help with vertigo?
If you have pain in your neck, cervical treatment will help with the vertigo. As far as drop attacks, that's another story. That's an inner ear problem usually. It can be also caused by vertebrobasilar insufficiency. You can get a drop attack from that. And if you're an older person and have a problem with your blood vessels, so that has to be determined whether it's due to the inner ear or due to something else. If you just have drop attacks without any ear symptoms, it's probably not due to the inner ear.
And then Vanessa is asking about the ear care website.
I posted that in the chat.
Great. What are drop attacks? I think we've talked about that one. Let's see. Please explain an endolithic sac decompression procedure in your
Okay,
opinion.
I don't believe that in that operation, so I can't discuss it very much. But the idea is to decrease the pressure in the inner ear by opening the sac, which is connected to the inner ear. I did 110 of these operations, and my son, who was doing research with me at the time, came to me and said, "Dad," he said, what's this sac operation you're doing?" I said, "Oh, it's an operation for Meniere's disease." He says, "Well, I want to tell you, it doesn't work." And he was going through all the charts and charting what happened to the patients after the surgery. And many of these patients came to further surgery afterwards, or would just continue to have their attacks. So I'm surprised that it's still being done today.
And then he also asked, doesn't gentamicin eventually cause hearing loss?
Gentamicin can cause hearing loss, definitely can cause hearing loss. But I've done research and put dilute gentamicin in patients with good hearing, and it has not destroyed their hearing. So if you're very careful with it, you can be, the hearing can be preserved. And occasionally you have to accept the risk that there's a possible you can have some hearing loss from it. But if it's done properly, hearing loss does not have to be a main problem.
Marilyn says, I recently developed a balance or dizziness issue. 5 years ago overnight, I developed ear fullness, a tinnitus, which I describe as buzzing or hearing the room, and a hearing loss in the higher frequencies. To make an appointment, is all testing done the same day? I live in South Florida.
Yes, all the testing can be done in one day.
We'll typically do the full test battery like I talked about, and then we'll have a follow-up appointment usually the next day, so I can get the report written up with plenty of time for Dr. Silverstein or one of our other providers to review before seeing you. Does sound therapy assist with improving tinnitus?
Yes. Anything that masks the noise will help the tinnitus, because you won't hear the ringing in the ear. And that's the main treatment for tinnitus, is that if it's keeping you up at night, then you have to use white noise or some ocean noise or crickets or some kind of noise that will mask the noise in your ear. So that during the day, usually the tinnitus does not bother you very much because there's a lot of noise going on that's masking the noise that's coming from your ear. You're not paying attention to it.
Mhm.
So so sound therapy can I think may be helpful.
And making sure to get a hearing evaluation done
Yes.
with some tinnitus or tinnitus testing performed as well can help us figure out where the pitch or frequency is for that ringing that you perceive. And then we can make sure that we get the best treatment plan for you when we do use sound therapy. So,
Right.
any associated doctors in SoCal that do the WIC procedure?
And where?
SoCal?
Where is that?
Southern California.
Yes, Ronan Nazarian in Los Angeles.
And then we can put that
I already put the link in the.
perfect on it. We've got the link for that in the chat for anyone to review. And then he also said, alternatively, can this be done on a travel basis, flying a problem after the procedure?
Yes, you can have it and then fly afterwards, yes. Yeah, we've done that.
There aren't any more questions in the chat. Does anyone else have any lingering questions?
Okay, that's perfect because we're out of time. It's past 1 o'clock. Got to get to work.
Yeah, well, thank you everybody for joining us today.
thank you.
It's been great having this discussion with all you guys. So if you have any more questions, feel free to call our office or, come see either of us for your dizziness.
Okay,
All right.
terrific. Thank you.
Thank you.
Bye.